Okay, so we're going to get started here. My name is Dr. Joshua Elston. I'm a board-certified plastic surgeon in Gig Harbor, Washington, and I specialize in treating lipedema, particularly with awake surgery. But because I'm a board-certified plastic surgeon, we can also treat lipedema in a surgery center or in a hospital. I'm going to be giving a presentation this week in France to a society of dermatologists, and I'm speaking specifically about lipedema and in an effort to help them diagnose lipedema and see it, because they get referrals for leg swelling all the time. So I think it's important that they understand what lipedema is, and I wanted to be able to share this with everyone else that might be interested. So if you or someone that you know would be interested in watching this, please watch it, please share it, comment on it if you're watching it on YouTube. I'd love to hear your thoughts on it, and if it's something that everyone is interested in, then maybe we could do more presentations like this in the future. So without further ado, the presentation is called Lipedema, the disease you simultaneously know everything and nothing about. So I'm a solo private practitioner in plastic surgery in Gig Harbor, Washington. I've been in practice for about 2 years. I focus on lipedema surgery, and I perform about 100 lipedema surgeries every year. Why lipedema exactly? I always wanted to be a reconstructive surgeon. That was always what my focus was. And as I moved out of a multi-specialty practice and on my own, I was doing a little bit of cosmetic surgery, and there was a high demand for lipedema surgery. So geographically I was advantaged because no one was really doing it in the area, and they turn out to be very, very happy patients. So I think I'm uniquely good at treating it, and I think the patients are uniquely happy, and they tend to be very appreciative, and that kind of makes me feel good, which makes it easier to treat lipedema. So I think we found a really good match, something that I'm good at, patients that are happy with me, and it kind of strokes my interest for reconstructive surgery and helping out people with functional problems that want to feel better. So I work out of a Joint Commission accredited office-based surgery center, and I'm board certified by the American Board of Plastic Surgery. I also operate in accredited ambulatory surgery centers and a level 2 trauma center. This is me and my wife, and then this is basically what we do in our free time. We go camping a lot. We like to be outdoors in Washington, and don't believe what everyone tells you. It doesn't rain all the time. We walk our dogs out, and it's beautiful all the time as well. So the outline of this talk, we're going to be talking about what is lipedema, what causes lipedema, some of the symptoms, how to differentiate lipedema versus obesity, and then we're going to be talking specifically about the cutaneous manifestations, because this is a lecture for dermatologists, so something that they'll understand. And then some of my favorite things to talk about are conspiracy theories. So we're going to be talking about how lipedema might be masquerading as other diseases, and then ultimately, if you were a dermatologist or a primary care physician, what do you do when you find out that a patient has lipedema? What's the next step? So what is lipedema? I mean, I think this is a brilliant abstract here that kind of goes over what it is. A condition characterized by swelling or enlargement of the lower limbs due to an abnormal deposition of subcutaneous fat. Talks about the genetics, where it's predominantly females that have it, and there can be some variability about how it's inherited, but it's an entity distinct from obesity, especially the distribution of it, and it's really easy to tell once you know what you're looking for. And it's also, most people that have obesity or normal fat don't have the pain, the bruising, and the tenderness that's associated with lipedema. So a lot of people will get lipedema and lymphedema confused, and so I put this chart up here to kind of show the difference. So we know that lymphedema can be acquired, and most commonly in the US it's going to be associated with some type of cancer surgery when they remove lymph nodes. It can be traumatic, or it could be congenital as well. Whereas lipedema, as we mentioned before, has some genetic component to it, and there's some variable expressivity or penetrance, meaning that it doesn't show up exactly the same in family members. So you could have a mom, a daughter, and a grandmother, and they may show different degrees of lipedema based on their different factors that they've kind of grown up with. You can see the phenotype, or kind of how it looks, very, very early in life, but ultimately the clinical presentation of the symptoms can be extremely variable. I think some of the things that are really important to notice between the two of lipedema and lymphedema and how to differentiate: lymphedema can be in anyone that's had lymph nodes removed, but lipedema tends to be more female only. Onset is typically puberty, or sometimes even sooner. People will see it before then. With lipedema, it's always going to be symmetrical. There might be some slight variation once you get to be more severe, but typically it's a symmetric swelling. The feet and the hands are usually spared until the very, very late stages. The skin consistency is usually soft and normal to thin, And then you often have bruising, pain, and tenderness, whereas with lymphedema, you tend to have thickening of the skin due to the lymphatics being blown out, and you have infrequent tenderness, pain, or bruising with that. Also important to note that with lipedema, little effect on the legs, and we'll get into that some more. So again, what is lipedema? The late stage disease is always really easy to see. Someone that comes in like this patient's had massive weight loss with bariatric surgery, but still, if this is not just loose skin, this is heavy skin that still has fat in it. You can see the areas where the lobules have formed around the inner knees. You can see this patient's developed lymphedema in their lower extremities and in their feet as well. So I think looking at the end stages makes it easier to start to diagnose someone that's early on that may not realize they have anything at all. So in early disease, it can be very subtle. And I think a lot of people would see this patient and she came in for cosmetic liposuction, but really when you start to look at where the fat distribution is, you see a little bit starting to form on like the saddlebag area or the outer thigh. We start to see some fullness on the posterior calf here. You're starting to see some nodularity or cellulite on the posterior thigh. And really, to me, I think if you start to look really, really closely, you see this kind of inner knee bulge. You see the bowing of the knee going in that way. And you can also see the bowing of the ankle, which are kind of subtle signs that show that you might be having some joint laxity. So, this patient really has cosmetic symptoms, but it's really curious why some people that are very mild in disease have more severe symptoms early on than someone that's very advanced that maybe just notices that they've got all this extra skin and heaviness, but they don't necessarily have the same kind of pain. So it's very variable on how people show up with lipedema. So I think this is a really good illustration here because lipedema will tend to start with very early swelling. So you can start to see the lower buttocks, the outer hips start to get swollen. There's a protrusion on this sacral area here, which to me is almost like pathognomonic for lipedema when you see a sacral fat pad. And then it progresses to even larger swelling. And you can see where this is disproportionate but symmetrical fatty growth that is tender to this patient. And then eventually, as it continues to progress, you start to get deformation of the area where it's kind of growing beyond the borders of normal anatomy. You're starting to get the dimpling, and then this area is exquisitely tender to palpation and actually causes problems with the lower back. In my opinion, there's really two different phenotypes or how lipedema shows up in patients. So I know people talk about all the different types and how they can like overlap. To me, it just seems like you're catching patients at a weird snapshot in time. So typically, like for the arms, that seems to be the area that is least involved or the last to be involved. Not always true, but for the most part, people are going to have some component that is involved in their legs, in their hips, their buttocks, and their thighs, and then their arms will kind of be affected later on, most often. So for me, I see basically two types. It's the patient that shows up that looks like this, that kind of carries it mostly in the anterior thigh. They got it on the hips and the butt. They can have pretty significant arm involvement, but when you go down to the legs, they don't have that classic cuff down here. They might have involvement on the legs, but it tends to be more posteriorly where they accumulate their fat, and the anterior leg is relatively spared. But these patients, they tend to have more like hip, butt, thigh involvement, less of the lower legs, and then they will have some in the arms. Whereas like the classic lipedema that we see a lot in diagrams is that kind of column, tree trunk leg, severe cuff on the ankle, where it's a little bit more symmetric. These patients tend to have later arm involvement, at least in my opinion, and they tend to have less lobules. It's more of like a symmetric, like sock-like or stocking pattern of fatty accumulation. So again, normal hands and feet in lipedema, that will help you differentiate it from lymphedema. And one of the diagnostic criteria that most insurance companies want to know about is something called a Stimmer sign. So it's used to diagnose lymphedema. And when you're talking about a sign, when a sign is positive, that's when you find what you're looking for. So if you're looking to diagnose lymphedema and you go to pinch a foot and you can't do it, that suggests that there's lymphedema there. So if you have a negative Stimmer sign, meaning that you can pinch the skin, it is not lymphedema, and that is more suggestive in the setting of swollen legs that the patient has lipedema. So really important to document that. So what causes lipedema? We spoke a little bit about genetics already. There's clearly some paternal inheritance link, and there's a clear family link in most patients where they talk about, oh, I always knew that I was going to get grandma's arms, or my family were just built that way. So you hear a lot about, people kind of understand that that there's some genetic component to it without understanding clearly what it is. We know that hormones play a large role in this, so it's usually present at puberty, and then we notice a blossoming, sometimes in pregnancy, where people just don't really lose their baby weight. And then at perimenopausal state, it can be a very rapid progression. Some people will kind of not really notice it or not really be that bothered by it. And then they hit menopause, they're like, I just blew up. You know, it was just like in the last year or two, things went crazy. And then I think there's got to be some other environmental factors or diet or some links to some other diseases that we just don't really understand well yet. And then part of what I want to talk about today is one of my favorite things to talk about, which are conspiracy theories about maybe lipedema is actually masquerading as some other diseases that we just call other things and we inappropriately diagnose. So what are the symptoms of a patient with lipedema? So I put this up because I think early disease and late disease really have very, very similar symptoms. It's just that you recognize them for different reasons. So patients with early disease can have actually pretty profound pain to light touch. And even with compression, they can't tolerate it because it hurts too much. They'll get restless legs that prevent them from sleeping, and they kind of have this achiness. And eventually they'll just kind of gradually slow down. You know, they'll notice that they're a little bit more fatigued with exercises that usually weren't as difficult for them, or they have a harder time running. They're not able to lose weight in the areas no matter how much they train. And often they have, some reported history of having a difficulty with wearing some type of clothing. So it's like, oh, my ankles don't fit, or I can't wear ski boots, or, I don't like the way that my shirts rub. And often these patients can develop depression or eating disorders because they just don't, something's not stacking up. They're dieting like crazy, they're exercising like crazy, and they're not losing weight. And I like to talk about it as a form of cognitive dissonance, where they know that something's just not correct with what they're doing when they're not getting the results that they expect. We see the same thing in late disease. The problem is just higher in magnitude. So it's not just like restless legs, it's like extreme heaviness and decreased mobility. They can't do anything. Sometimes these patients are disabled or they're locked in the house because they can't get out and do anything. They're definitely unable to lose weight because they've lost their mobility and they can't get to the gym or do anything to exercise anymore. It's very, very challenging to find clothing that fits because you're trying to size the clothing to these really large, disproportionate areas. And then at the same time, these patients can also get very depressed and develop eating disorders. So what's the difference then? If it's the same presentation, the same symptoms in early and late disease, I think when I was in my psychiatry rotations in medical school, you could find someone that has a quirky personality, and at what point does that quirky personality become so severe that you talk about it being like a personality disorder or pathology? So I think the same thing with lipedema. We'll see a lot of patients with early disease and they don't really have symptoms. So like you kind of see the pattern there. But if it's not bothering them, is it really considered a chronic disease? Maybe at some point it'll progress, but I think it's important to distinguish, is this something that's bothering the patient? Because if they have very mild disease, but very severe symptoms, I think that's worth treating because those patients do tend to get better. But then similarly, you might see someone that's got relatively late disease, like stage 3, and they're not all that bothered by it. So, are you really going to make them go through 3, 4, 5 surgeries to make them, not really feel that much better if they're just kind of getting on with their life? I don't know. It's a very personal decision. I think patients should have the option. But to me, this is kind of like the calculus that I look through when I'm deciding when to diagnose someone with lipedema is, are they having functional problems? Are they having some type of functional impairment? Are they at risk of developing an eating disorder because they're not able to get the results that they want from diet and exercise? And this is really part of the discussion that we have. So in early disease, patients can get frustrated because they appear mild and they can be blown off by people who are like, you're crazy. You don't have that much fat. What are you talking about? You don't need liposuction. And to me, it's when I see what appears to be a reasonable person acting unreasonably, that makes me kind of like have my spidey sense go off. And I think to myself, maybe there's something going on here that I'm not seeing. Maybe I don't have the correct diagnosis. So when you see a patient that thinks that they have lipedema and they're complaining about all the things and they're not very severe, it's probably because they really have all the symptoms. It's not that they're trying to like get free liposuction. No one wants to really have a chronic disease. So I think these patients have a cognitive dissonance and they understand that the reality that they're living in does not match with the effort that they're putting into it. So again, we talked about how this can lead to some issues down the road. In late disease, patients have an opposite problem because they appear severe and they're just dismissed because they're overweight. So they feel gaslighted by providers and they feel like their time is wasted due to a lack of diagnosis or delay in diagnosis. So they'll often go through, oh, well, you need to have weight loss surgery before we even consider anything like this. Or they'll put them in weight loss and diet and exercise programs or prescribe them supplements that, all of it just doesn't really work all that well. The best treatment for lipedema is liposuction. So moving forward, I think it's important that we then talk about lipedema versus obesity. How do you differentiate it? So to me, it's really where the fat is distributed. So in obesity, we'll see it more centrally. So in this patient, you can see that she's got more of her fat in the central area, a little bit around the hips, but mostly in the abdomen. And then when you look at the lower legs, you see that there's still the tapering in this area. The knees are relatively skinny. If you looked at her feet and her hands, they're relatively normal. Whereas in this patient, again, like similar fat distribution in this area, but when you look at the thighs, they're more full. So the thighs kind of touch together here. When you look at the lower legs, there's not as much of a slender taper. It's more of like that kind of hip, butt, thigh lipedema distribution that we talked about earlier, a little bit less on the legs. So, these are patients of similar weight, but they kind of hold their weight in different areas. So in fat or obesity, you don't spare any area. So they will often have swollen hands and feet and fatty accumulation there or in their face. Whereas with lipedema, you tend to not see that as much. The hands and feet are typically normal, and the face and the collarbone area in particular can be very, very skinny despite having an elevated BMI. So you tend to see lipedema more often in the periphery. In terms of responsiveness to weight loss, obesity is very responsive. So those people that have weight loss surgery, they'll lose weight everywhere, and eventually they can look like they're wearing a skin suit. I mean, it's like you can have such profound weight loss. Whereas with lipedema, you don't really see that. You might lose some weight, but you tend to still hold it in the areas like the thighs, the legs, the arms, the hips, and the butt. Also with lipedema, they can swell pretty profoundly throughout the day, or if they are in some type of situation where they have surgery or some illness, they'll retain a lot of fluid, particularly in those areas of lipedema. And so then like looking at the effectiveness of liposuction, lipo for obesity can be a little bit unsatisfactory if you do it in an area that isn't, for a patient, it's not a good candidate. So like someone that has like central obesity, they can have it on their visceral fat, which is internal. And if you do liposuction externally, they might still feel like they have a big gut, so they may be unhappy. Whereas for lipedema, when you do fat on these areas, it can actually help them to lose weight when you get all that hormonally active fat out from those areas. And they often have a decrease in their symptoms of pain, tenderness, and also bruising afterwards. So again, for this talk, because it's geared towards dermatologists, we're talking also about the dermatologic manifestations of lipedema, things that you might see that could help you diagnose or clue you in, even if a patient's not complaining about the symptoms of lipedema. So one of the big things is hypothermia of the skin. So when you touch the skin, it'll feel cooler in areas of lipedema. You have cellulite and nodularity of the skin. So we start to see it here in this milder patient, that you start to see the pebbling of the skin and some dimpling. Whereas here it gets much more severe. You can have livido reticularis, which is this kind of net-like pattern of blood flow on the skin. It's more common with heating pad use. And then in this patient, you can see that she started to develop lymphedema and has progressed to stage 4 from lipedema. So to me, speaking again about cellulite, when I hear that someone has cellulite, it's almost lipedema until proven otherwise. So there's a lot of focus placed on this connective tissue that kind of tethers the skin to the underlying fascia. And everyone focuses on like dividing that or cutting that to reduce cellulite. But there's two parts of it. It's not just the tethering of the skin, but it's also the growth of the fat around the skin. So I think that this deserves more focus, not so much the tethering of this, but also how should we reduce the fat that'll make the appearance of cellulite less. And I think that's really the problem with lipedema, why you get the dimpling, is because the fat overgrows and the connective tissue just doesn't really want to stretch. It's the point of most resistance. So other dermatologic manifestations, we'll start to see venous insufficiency, and this can get pretty profound, both in the thighs and the legs. You can see large varicose veins, and sometimes this can improve with surgery as you decrease the pressure on the venous system. We see cutis laxa, or loose skin, that can be on the arms, on the abdomen, on the thighs. Bruising is very common from capillary fragility. And then you can also start to see pendulous lobules of fat that kind of hang over the knee or the ankle. So finally, conspiracy theory time, my favorite part of this. And I know my wife's going to kill me when I do this presentation in France with her. So this is my favorite part. So I think this is something that it just seems logical to me. And I think that we're going to figure out over time that a lot of these conditions that we thought were one thing are actually lipedema that is just being incorrectly diagnosed. So we spoke a little bit about obesity, how these can actually coexist together. You can have lipedema and not be obese. You can also have lipedema and have obesity. So just because you have one doesn't mean that you can't have the other. So I think, again, it's important to understand the distribution of patterns of where the fat accumulates, but you can still have both of them. The real thing that I think is interesting to talk about are restless leg syndrome and fibromyalgia. So with restless legs, patients complain about aching, swelling, tender fat. They can have venous disease that leads to pain at night, and it's difficult for them to get comfortable and sleep. And then with fibromyalgia, point tenderness, massage that can help. And I think this is really like a diagnosis of exclusion. When I was in medical school, we were told that people that have fibromyalgia are kind of like wacky, and that it's like this weird diagnosis, and that they were kind of crazy, and it's usually people that are overweight and they're females and then they're in their 40s. So I want to talk some more about those things today. So we kind of talked about obesity already. Let's talk about restless legs. So these are pulled from the Mayo Clinic. So it's a condition that causes a strong urge to move the legs. Mostly happens in the evening or night when lying down, can begin at any age. So there's relief with movement, stretching, jiggling the legs, pacing or walking. That kind of sounds a little bit like a vibration plate or lymphatic massage to me. Worsening of symptoms in the evening, like almost like if your legs were swelling throughout the day and then you feel it most at night. And then the thing that really gets me is like when I see these, the sensations are felt within the leg rather than on the skin. They're described as crawling, creeping, throbbing, aching, itching, and electric. I hear patients with lipedema talk about this all the time. This is exactly how they describe it, and they usually describe it when they're early on. So the patients that are stage 1 that like appear kind of wacky, like they don't really have anything wrong with them to other providers, I think this is what's going on. I think they're having these sensations and their nerves are irritated from the swelling of the fat. And I think that when you start looking a little bit more into it, you'll start to agree with me. So there's a hereditary component to restless leg syndrome. It runs in families, especially if it starts before 40. Pregnancy or hormonal changes may worsen it. What does that sound like? Risk factors, more common in women, can develop at any age, even during childhood, almost like if it developed in puberty or something. Again, we've got the sensations. It's hard to explain. Medications to treat it. Well, I mean, like medications that like treat depression and like increase dopamine in the brain. You've got gabapentin, which I find is a really helpful medication for people after they have liposuction of their lower legs, like because of the nerve pain. And man, I couldn't imagine treating someone that had restless legs with opioids, knowing what we know now. But apparently, that's a medication that's justifiable. So. If we're talking about fibromyalgia now, so it's a disorder characterized by widespread musculoskeletal pain, accompanied by fatigue, sleep, memory, and mood issues. Okay, so it can happen after an event such as physical trauma, surgery, or infection. So all those to me sounds like things that could make you swell or be in a fluid retention state. Symptoms may gradually accumulate over time with no event. Women are more likely to develop fibromyalgia than men. Many of them have anxiety and depression. Exercise, relaxation, and stress reduction may help. So let's keep going here. Causes, genetics. It might be more common in families. Your sex, it's more often in women than in men. So, I mean, these things are starting to sound like something that you might see in lipedema. And then talking about the diagnosis here, you need to have 4 of these 5 areas where you have pain. So the left upper region includes shoulder, arm, or jaw. Shoulder, arm, or jaw on the right. Hip, buttock, or leg. Hip, buttock, or leg. Back, chest, abdomen. I mean, these are all areas where people are constantly complaining about tenderness to pain. And when you go and press on them, it doesn't take a lot to elicit pain in a patient with lipedema. So what's the therapy for fibromyalgia? Okay, well, you're going to go to a physical therapist that's going to do water-based exercises. That's really, really helpful to move the lymphatic fluid around in patients with lipedema. Occupational therapy, counseling, I mean, like, these are things that like help out lipedema patients a lot. Again, like, there's no science behind what I'm saying here. This is just kind of like, I wonder, I see some patients that come in and they've got diagnosis of fibromyalgia and they've been on Lyrica and other types of medications and they just don't really help, or, they seem to not really help that much, and their pain gets better after surgery. So it's just kind of one of those things. I'm not trying to knock all the people that have diagnosed fibromyalgia over the years. I just think that they just didn't really know what lipedema was. And I hope that by kind of talking about this, I think that, I kind of joke about it being a conspiracy theory, but maybe it's just that we don't have the correct diagnosis. And once you get that diagnosis established, you can get a patient off of medication, get them to the therapy that they really need that's going to make them feel better. So what do you then do? If you find a patient that's got lipedema that doesn't have a diagnosis yet and you suspect it, I think the most important thing is get them into compression. That's going to be usually the time, the component on their insurance that requires the most time. Usually it requires 3 to 6 months of compression therapy that they've failed before they're going to be a candidate for surgery. I think it's important to refer them to a plastic surgeon that's experienced in lipedema. You don't want someone that just kind of dabbles in it and does cosmetic liposuction. I think it's important to do referrals to either physical therapy or massage therapy. Some patients will actually fail that therapy because it hurts too much to do the massage or the MLD. I think online support groups are fantastic, so they can speak to other lipedema patients that have tried other surgeons, and they can kind of find out who's going to be the best fit for them. And then I think it's also worthwhile to consider a vascular surgery referral if they've got really significant venous disease and they might benefit from varicose vein removal. And lastly, these are just some of my patients that kind of illustrate that lipedema comes in all shapes and sizes. So here's a patient with stage 2 disease who had liposuction of her lower legs. This is an on-the-table result. Here's a patient that had her insurance cover 4 surgeries. So we've done her hips, her butt, her thighs all the way around, and her lower legs. She's got significantly less pain and a much better energy and ability to exercise and hike. Here's a patient with really severe stage 3 to 4 lipedema that's had 1 surgery. We did high volume liposuction in the hospital on the front of her thighs, knees, and legs, and removed over 13 liters in 1 session. I think you can see the pretty significant difference there. So that's over 20 pounds of fat removed in 1 session. Here's a patient that's in her 30s with stage 1 disease. And again, this kind of demonstrates that pattern of what the knees kind of move inward, and also the ankles move inward because they have the connective tissue disease and the joint laxity. But she had some pretty mild disease, but pretty significant heaviness and inability to keep up and play with her kids. So this was a big deal for her to get this surgery. And even some patients that are older show up. So this is a 74-year-old patient that had a facelift, and she also noticed that she had some heaviness of her legs. So we did liposuction on her legs, and it was a wake surgery. She recovered very well, aside from some prolonged swelling because her skin is a little bit more thin. But I think you can see that she's got a much better shape of her lower leg. She's got much less heaviness and a lot better contour. Here's a patient with pretty significant disease on her thighs. They've already been done here, but this is to show that she had pretty significant bruising and really bad pain on the lower legs. And this was after 1 session where we removed about 5 liters from her calves. And I just want to say thank you for listening into this. If you don't know us already or follow us, again, my name is Josh Elston. I'm a board-certified plastic surgeon in Gig Harbor, Washington. I specialize in lipedema surgery, and I specialize in awake surgery in particular. If you like this, please consider following us on either Instagram or YouTube. It's at the Elston Clinic for both of them. If you have any questions, please leave a comment, and I really appreciate you listening to this. I hope I didn't scare anyone off with the conspiracy theories. I love talking about lipedema. I love doing education. If you ever wanted to get a consultation from us, we do free virtual consultations. We see patients from out of state, out of country all the time. So we'd love to have you as a patient, or if you know someone that would benefit from seeing this, then please consider sharing it with them. Thanks.